Welcome back to the Runner Zone podcast. Chris, what's up, man? We haven't done one of these since before the holidays. How you been?
Things are good. How about with yourself?
Good. Yeah, it's Tuesday, and we got maybe 6 or 7 inches of snow in the last 24 hours. So my kid's school was canceled today, and I was supposed to be in the clinic today. So that schedule got shifted around a bunch, which is fine. One of the benefits of this. So it's been a kind of bouncing back and forth between working and then going and building a snowman, and then the fun parts of having kids at home in the snow. So it's been good. This is my second cup of coffee for the day, which is pretty standard at this point.
I've never asked you, how many cups of coffee do you drink per day on average?
So I will do 2. I make a pour over. If people are watching on YouTube, I make a pour over about every morning in this glass, and then sometimes I'll make another one, and that'll be normally around lunchtime. If I'm not careful, I will drink coffee all day. So I try to limit myself to just in the morning when I wake up, hopefully before my kids get up. That's the peaceful time of the day for me. And then maybe once more around lunchtime, and then call it good from there. What about you?
I drink 3. I usually will have 2 in the morning and then 1 in the afternoon, but it has to be before 3 p.m. because otherwise it does seem to keep me up. I've made the mistake. I forget that kombucha has caffeine in it. So last week I drank a couple. I'm like, why did I sleep so poorly? And Mimi was like, why are you drinking kombucha so late at night? You know it has caffeine. I'm like, don't.
Yeah. I will drink. That's true. I will drink kombucha, and then I drink tea, but I generally drink tea in the second half of the day, and that is non-caffeinated.
Yeah, Seattle, you would definitely bump up to another cup. It's just like this time of the year. Yeah, and you have to be careful of going from drinking coffee at 3, and then you're like, wow, it's dark out at 5 p.m. Man, I'd love to have a beer. So anyway.
Yeah, anybody that met me when I first opened up, the original location that I started my business in was a treadmill studio, and we were literally right above a coffee house. So, 50 feet from work was coffee, and the people were super nice, and it was kind of outside. So that was a problem because anytime, when you start out, it's not like your schedule's slammed. Yeah. So, easy to just kind of walk downstairs and, oh, this is like my third time I've come here today. Probably not ideal.
Yeah, that place is awesome. They did have a good vibe. Good. Yeah, good coffee and just a great place to study. And yeah, I always have fond memories of that place from when we taught courses there. What are current recommendations? So, do you advise, obviously you're not a nutritionist or RD, but when people are like, hey, when I go to race, I like having a cup of coffee. Do you have some numbers to throw out for listeners in terms of caffeine recommendations?
That's a good question. I don't give out any recommendations from that aside from do your normal routine. Yeah. So if you normally drink coffee in the morning, drink coffee in the morning. Don't change up something that you're not used to. What about you? I normally leave that stuff to Becca just because most of the time the people that are working with me are working with her as well. So I'll let her handle that.
Yeah, I'm sort of I take a similar approach to you. I just tell people, what do you typically do? What have you rehearsed? Let's not do anything to surprise your system. I think that the research is 2 to 3 milligrams per kg body weight, around 30 to 60 minutes, maybe like about 45 minutes prior to competition. People used to talk about abstaining from caffeine in the week leading up to a race, but I think that's been debunked.
Oh yeah, I remember that. Kind of this idea that you would take it away and then you throw it in right at race day, and maybe it's going to give you a little bit of a performance boost. But
yeah, I used to always be careful about when I was racing Ironmans. Not that I'm done racing, but the half-life of coffee, I think, is about like anywhere from 5 to 7 hours. So let's say 6. So I used to not actually drink it in the morning, but I would start dosing it when I was on the bike just because I wanted it in my system, especially as I got later into the race. But Yeah, great ergogenic aid, right?
Yeah. Oh, it's great.
Yeah.
Yeah, keep it the same. Use the same beans, use the same brewing method. One of the things I've learned about a lot in the last year, there's some great books on kind of the science behind coffee and different ways of extracting it, and what it really means to be at different elevations and things like that. How quickly it will go stale, and um, yeah, keep everything the same. So don't use new beans that you're not used to. Don't use a new method that you're not used to. Just keep everything the same.
Do you drink it black or do you put cream in? Probably not black,
Oh,
right?
come on, man. That's what kind of question is that? So all black. So
Yeah.
yeah, black coffee and espresso.
Yeah.
I used to put a ton of stuff in it. I just don't like the taste of it anymore. I don't like the
Yeah.
taste of having any kind of cream in it. It's probably because I'm
Yeah.
getting old, you know?
Yeah. We got one of those Nespresso machine. We actually have two of them. There's one in the office here and then one inside. But I'll put a little bit of milk in there. But if I'm drinking coffee, yeah, I drink it black. Yeah.
Yeah. I like the
Yeah.
taste though. I mean, do whatever works for you, right?
Yeah.
I'm not going to bash on anybody's preferences.
Yeah. Does coffee stunt your growth? My dad used to tell me that when I was younger.
That's a good question. I don't know. Maybe. I
There's
mean,
all
it's
this nonsense that we were told,
well,
right?
like if your 8-year-old is drinking coffee, I think you could probably make the case that's not the best decision.
Yeah.
Maybe it's because they're gonna end up 2 inches shorter, or probably other
Yeah.
reasons too. But
And eating the crust makes your hair curly, right?
I've never heard of it yet. I do know the reason why I started drinking coffee was my first year of PT school. It was we had anatomy 4 days a week. It was at 7:30 in the morning. It was with Dr. Robert Anderson, and Dr. Anderson would use a chalkboard, a green chalkboard in chalk, and he would draw. That was the whole class. Was
Oh,
he would
painful.
draw the brachial plexus. He would draw the lumbar plexus. He'd draw this different, and all he would do is draw. And I remember sitting in this like auditorium at Rockhurst thinking, I mean, I find this stuff fascinating. I cannot stay awake,
Yeah.
So I'm going to have to do something. And so that's what started me drinking coffee. Back then it was with creamer and all that kind of stuff in it. But I stayed away from it till I was in PT school. And then it just became a necessity for me to pass.
Yeah. I hear you, man. I do think there's something about writing things down, like on that note, where so long as you're awake and you're caffeinated, that you process it a little slower. And I always find that for me, that helps to sort of lock in the information. But
Yeah, I mean,
anyway,
if you look at any of the books that are behind me, like I write in all my books because it's easier for me to remember stuff. Going back to college and PT school, I would rewrite my notes. So
that's how I
you'd
did
go
it.
through
Yeah.
something, and if I had time, I'd go to the library later and I'd kind of rewrite things. That's always been the easiest way for me to remember things.
Yeah. 100%. Yeah. Cool. Well, happy New Year to everyone. We hope you're off to the start of a good new year, and let's get into it. Yeah.
Yeah, we do have one announcement. So you and I are going to be teaching at Gig Harbor on February 24th and 25th, our Bone Tendons, Weights, and Whistles course. Um, we taught this a few times in person last year. We've taught it in person before. So excited to bring this back out to the West Coast. And it should be a fun weekend. It'll be near Gig Harbor's kind of close to Tacoma, and Point Defiance Park is my favorite place to run. It's down there near Tacoma. Back when I lived out there for a summer. But it should be a good time. If people are interested in that, you can find a link to learn more in the description of this episode. And obviously, if anybody has any questions about anything, you can always shoot Chris or myself a message. But it should be a good time.
Is that in your? I know I have it in my Instagram bio. Do you have it in yours as well? Just to make.
Yes.
Yeah.
Yep.
Cool.
It's in my Instagram bio too.
Yeah.
So should be a
That
good
course
time.
is just fun to teach too. And I mean, talking to clinicians, we've always maintained one foot in the clinic. So yeah, I love teaching that course. So
Yeah,
that'll be fun.
it'll be a good time. Today's topic, though, is going to be about probably the most common thing we deal with, which is pain. So, you know, it hurts when I run. What do I do? Most of the time, when people come and see either one of us, if they're seeing us in the physical therapy capacity, pain is their big thing. It's up front and center. It's causing them a little bit of grief, and so how to navigate that. I thought it would be good to kind of go through maybe some different situations and considerations for how we go through that with our patients, and then on the athlete side as well.
Yeah, I mean, this is really the main reason that people consult us, right? And I think people have very. I just consulted a guy last night, and I was trying to get him to conceptualize his situation. He's dealing with patellofemoral pain. I'm like, there wasn't a traumatic injury. Your knee has gotten sensitized, and he was like, "Can you explain that more?"
Mm-hmm.
And these are very nuanced conversations, and it's something that I'm sure you're similar to myself in that we continue to refine these explanations and our understanding, and it's just such a complex thing.
Yeah, and
Um,
most of the time, the patients that I see, probably similar to yours, they feel like they're in this holding period. They don't really know something hurts, whether it's their knee or their hip or their foot, and they don't feel confident with how they should be approaching it. Do they need to be resting longer? Maybe they've rested, it hasn't improved. Do they just need more time off? Should they be pushing through symptoms and just kind of toughing it out? What's okay? Are they doing further damage? I think there's a lot of anxiety around that decision.
mhm.
And I've experienced that too in training and in other sports growing up, where you feel something and you're like, I don't know how, if that's okay or not. And so I do think you can be in a position of kind of feeling like you're just stuck, unsure of which way to go with it.
Yeah, and everyone comes to experience pain with a whole slew of other factors that dump into that. And I think the first place to start is to really understand what's been, not only what's that person's understanding, but if they've consulted or spoken to other people, what's been communicated to them. Because you always hear, oh, let pain be your guide. That's not bad in all instances, but in a lot of situations it's very unhelpful.
Mm-hmm.
um, so when you, if we just take a step back and say, like, we have the International Association for the Study of Pain, and it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, we sure as hell aren't like explaining that to patients, right?
That's what
So
I say. I have that on the wall actually behind my table.
yeah, short-term goal, patient to verbalize verbatim the exact definition. Um, because running, I mean, the tricky thing about running is that running's sort of uncomfortable to an extent, right? It's
Mm-hmm.
not like you're just out on a Sunday stroll. So, helping people make sense of what they're experiencing is really important. So, how do you, like, when we think of the term pain, how do you typically describe that or differentiate it from, say, discomfort?
Yeah, I think there are some characteristics that are important. I think I try to encourage with patients that variability is generally a good thing.
Hmm.
So if you have pain, that it comes and goes, it ebbs and flows, it's high, it's low, there's variety in it. Maybe they experience it at different times during a run or in different situations. I think most people get on board with the fact that when you're running, there are moments of discomfort. Everybody who's ever gone for a training run, you've had 10, 15, 20 steps where you're like, my knee just, that does not feel right now, but it kind of goes away after that. So what I become more concerned with, or more, not even concerned, what I pay more attention to is if pain is consistently arising, it's stayed there for maybe multiple training sessions. So 2, 3 runs have happened and you feel something. And that doesn't always mean that, again, it's a problem. It might mean that we should tweak some things training wise, whether we're
Hmm.
talking about a patient or whether we're talking about a client. But really trying to understand how does this present and what all is it affecting? Because if it's only present with running, I think that's a very different situation than someone that says, my knee hurts when I run. I can't tolerate sitting. I can't really walk that far. That's a different situation. Um, because there's higher irritability with someone's symptoms, and so that might mean that there's more going on, but oftentimes it just means we probably aren't ready to be pushing training a ton right now.
Yeah. Yeah, it's I think you make some great points there. Yeah, I think the first thing that you mentioned, like if there's variability or that like the symptoms are Tobleroning, to
Hmm.
remind the person that's a really good situation, even though, they're obviously dealing with this situation they'd rather not be, but we see things warm up. Excellent, right?
Hmm.
Um, but
So
I think
yeah,
go ahead.
so I'll give you an example from a patient that I consulted recently. So runner had been experiencing what sounds like IT band syndrome. And this had gone on maybe a few months ago and had gotten to the point where they'd become really concerned about it. And so they just stopped running for a few months. And so they didn't run for 2 or 3 months, and then they tried again, and they experienced some symptoms around 2 or 3 miles. And their normal runs are maybe 4 or 5 miles at a time. They're not training for anything, but there does seem to be an element of duration is when symptoms come on. And so again, they came in kind of voicing a lot of concern about I don't know what I'm supposed to be doing with it. And so there wasn't a specific mechanism of injury. We didn't have any other symptoms. So they weren't talking about their knee swelling up. They didn't feel like they'd lost a range of motion in extension or flexion. There was no trauma to the area. They didn't have any numbness and tingling. There weren't any time periods where they couldn't weight bear on that leg. There was no really other concerns from their history. They had lateral knee pain that came on a few miles into a run, got to about a 3 or a 4, and then they pulled the plug because they were concerned about it. So I go through that, and I'm talking with them, and I'm saying, okay, so you can go through your day and you don't have symptoms. You can go up and down steps and you feel okay. Sitting's okay. You're not complaining of any instability. There's no other elements that you can really reproduce your symptoms aside from running. Again, to me, that's a whole different situation, and that's a situation where my initial advice is often we actually need to keep you running.
Hmm.
We'd probably want to modify what you're doing a little bit. So we've talked about cadence manipulation before. This patient fit pretty well within having her increase her step rate by about 5% and then splitting up that run. So instead of going all the way through 3 miles straight through, 4 miles straight through, let's just have you run for about 10 minutes and then walk for a minute and then keep those running intervals at a slightly higher step rate.
Yeah.
And that seemed to be all we needed to kind of push her in the right direction. Um, so again, pain, yes, but not something where I'm freaking out concerned about it. This isn't someone that comes in and again, I'm worried about a bone stress injury. Their presentation, their history matches that. And my advice is, oh no, you can't have any symptoms. Get on crutches and we got to get you in with a physician.
Yeah. So this is great, and I'm gonna bring up another case momentarily, but I want to spend a little bit more time on this. I mean, one of our advantages outside of having made countless mistakes is there's a different line of questioning when someone comes to see us and they're like, "Hey, I'm having pain."
Mm-hmm.
Okay, like we're locked in on that conversation. So give us a little bit more of a lens into this particular runner. So IT band pain. There's no
Mm-hmm.
traumatic episode. Were there any other remarkable things in this woman's past medical history that you think listeners, would benefit from hearing so they have a better understanding of or just more context?
Sure. So newish runner had been running
Very
for a few
important. Yeah.
years. Right.
Yeah.
That's why I brought it up. Newish
Yeah.
runner. So I've been running for a few years. Not someone that you would say runs high mileage. So very typical training week prior to this was 15, 20 miles a week. So this isn't someone that, they're in the midst of marathon training and they're running 50, 60 miles a week or something like that. Different considerations. Um, Again, no other really concerns from a health standpoint. No big changes in shoes. So we're not dealing with someone that went from they're running all their runs in carbon fiber shoes. They're made a drastic switch. No big changes in environment. So they aren't running on trails now. They normally run on roads or something like that. So the main thing was, and I see this a lot, they had been feeling good running. And so they had started running more than they were used to. So, and they had an active job. So they tended to be up on their feet a lot at work, moving around a lot. They'd also picked up more walking just outside with friends and things like that. So we had a big increase in just kind of overall training load, plus an increase in running volume. To me, that's that type of presentation. Running is almost always the solution. And I had this discussion with them when I saw them. You know, we worked on some exercises. So there's some things I think it'd be helpful to work on. They had 2 exercises that I'd like them to do a couple days a week, but I really think the most important thing for them at that point is to just build back some consistency with running. Even if they never did any exercises, I think they'd probably be okay.
And can you paint us a picture of if you were to watch this person running? I'm assuming you took them through a treadmill analysis or watched them run if you were talking about cadence manipulation, but what were some standout characteristics?
Sure. So step rate at a conversational pace was, I'd have to go back and check, but I believe it was about 156. And then had a slight crossover gait. So if you view the runner from behind or even from in front, it's almost like they're running on a line. So there's a little bit of a crossover with each foot strike. Not a really aggressive one, but one was definitely there. And those are 2 things we've seen tends to maybe place a little bit more stress on the IT band, that lower step rate, and then that crossover gait. You could say the same thing, honestly, if they had patellofemoral pain syndrome or patella tendinopathy, really any kind of knee pain. I think I would probably have the initial recommendations would probably have been the same.
And when she was running on level ground, was she initiating with the heel? Was she initiating with more of a mid or forefoot strike?
Yeah, so a mild rear foot strike, not
Yeah.
super aggressive. You'll see some people that have a really marked angle when they hit the ground. Not an overly aggressive one, but definitely one. And when we tried this in session, we had a change in symptoms. So that's another thing I'll do with people. And this is where I do think if you feel confident with the tissue that's involved, you can play around with symptoms a little bit. I think cadence manipulation is a great way to do this. Often I'll have runners that if we know symptoms come on in running and we've cleared other things to the point where we know that running is appropriate, at least from an analysis standpoint, that you can have them try different things, have them try different external cues, try alterations in their step rate, try different shoes, and see if they get a change in their symptoms. It doesn't mean that just that change is all they need to do, but I think it helps a lot with buy-in. It also helps a lot with their perception of pain. So you mentioned at the start, pain can be pretty individualized to the person based off of a lot of different things. So having them understand that their pain can be malleable, which often with running related injuries, it can be, that's really important, I think, to bring down some of their anxiety and to help with buy-in. So often if someone is still actively running and they're coming and seeing me, we will run and we will maybe play around with some of that to figure out the right situation.
And when you took her through a lateral step down, was that provocative?
No. So no other testing was provocative. So some of the things that when we teach this in our courses, when we teach together, so could do a lateral step down on both sides. There was some mild, instability from a balance standpoint, but nothing crazy. They could tolerate a bridge with straight leg raise. It was challenging for them. So that was another one of the things that was their home program. But no pain with that. No pain with pogo hops, bilateral or single leg hopping. Side plank wasn't provocative, although what was challenging. And so again, I become more confident with how should we be approaching this pain because I wasn't able to reproduce it with lower level testing than running. If all that stuff was painful, we might not even have gone through a gait analysis.
Yeah, and I think that this is a situation where it's like, you have to conjure up like this is ITB pain. It's like, okay,
Hmm.
recreational runner, initiating contact when on level ground with a rear foot strategy, um, you know, is having pain localized to that distal lateral thigh or outer aspect of the knee. You didn't comment on this, but it probably wasn't present. There is no presence of a knee effusion, so there's nothing intra-articular. And it's like, yeah, this is focus on the running, like really zoom in. That cadence being like in the high 150s, I mean, that's an easy lever to pull. Um, what guardrails did you put on her? Is she was basically when you were working together?
Yeah, this is again something that you and I both talk about a lot. Feel free to add anything that I might miss. So whenever someone is going back to a running progression or we're continuing to have them train, I do think it's important to have some guardrails. So in the presence of a tendinopathy or a fasciopathy, however you want to categorize this, I'm okay with them having some symptoms with running as long as it's really not above maybe a 3 or a 4 out of 10,
Mm-hmm.
as long as that pain goes away within 24 hours. So it might be stirred up for a little bit, but it should resolve itself relatively quickly. Um, we don't have any apprehension from them, so they feel okay with whatever it is that they're feeling. If they don't feel right, it doesn't feel right, feels off, it feels like too much. I do think it's important to help them understand they're in the driver's seat. So if there's ever anything you don't feel comfortable with, I want you to pull the plug. Either walk for a little bit, see if it goes away, or just stop the run. And we'll kind of reevaluate stuff, or changing their mechanics. So if they're having symptoms that cause them to change the way they move, I don't want them to push through that. And you could say the same thing with a home exercise program. So say we had someone on like a heavy front squat for whatever it is that we were seeing them for. If all of a sudden they felt like they couldn't do that because of symptoms, I wouldn't want them to push through that. So I don't want you to push through pain that's above about a 3 or a 4. Pain that they're concerned about, or pain that causes them to move differently. And then give them that kind of 24 hours to see how it behaves. And if it stays around, maybe we went too fast. Maybe we weren't quite ready for running. But if it resolves itself rather quickly, then I think we're on the right track. This is also why I think for both of us, we tend to advise people to start running every other day if they've had some time off,
Mm-hmm.
because it does give them a chance to recover and to assess how they're responding to whatever the run was the day before.
And in terms of hills, did you have any recommendations? Well, incline, decline.
Yeah, so we keep it relatively flat. They were running on the treadmill, which is probably a plus in
Mm-hmm.
in the eyes of the knee. Um, it's cold, and they felt comfortable with that. So I told them, if you want to, when you're going through your run progression, if you want to add a 1% incline, it's probably okay. It might feel a little better. So that's an option. And I try to lay all this out for people too. So it's not to say, become this robot that operates at a specific step rate, at a specific grade on the treadmill, in specific shoes at a specific speed.
Mm-hmm.
More along the idea of the most knee friendly way to progress right now is going to be these two things. And I want you to see what feels best to you. And feel free to play around with it if you're noticing that during your run.
When you were speaking to her about this situation, did you speak it or use the term injury, or how did you present that? Because I think this is a really these are very nuanced conversations.
Yeah, I will. I mean, I'll use the term sensitized or
Yeah.
irritable a lot, as opposed to injury. And that's the other thing too. We haven't talked about this yet. There's been so much literature now that comes out that talks about how pain isn't necessarily equal to damage. That this idea that if you have high levels of pain, you're creating a lot of problems. Um, I think often with tendons, people that have pain in their tendons, which is probably the most, or certainly the top two um, conditions we see,
Mm-hmm.
that pain means that tendon is one faulty step away from snapping, which again we
Mm-hmm.
see that's probably not the case.
Mm-hmm.
Um, and so I try to be careful with the words that I use around that. Some people are more sensitive to that than others, but I don't. I mean, rarely would I use. I'll use the word injury sometimes, but not that often.
Yeah. Yeah, I
What
think
about
that's
you?
yeah. I mean, I agree with everything you said. I think that was a good overview, and that's something that we encounter frequently in the clinic. Is a recreational distance runner coming in with lateral knee or distal lateral thigh pain. And I think that there is a very specific line of reasoning, because you have confidence that there's no presence of a bone stress injury, because if you're saying, oh, these are acceptable levels of pain, and this is great because I think back to a woman who had reached out and she was dealing with distal lateral thigh pain that manifested abruptly during a half Ironman race where she's like, I just had to stop running. I couldn't keep running. Like it just wasn't happening. And, same location in terms of symptoms, but she's a seasoned athlete. She's been running for probably 2+ decades. That's not someone who gets ITB pain, right? And the fact that she just couldn't press on is a little bit of a flag to me, unless she adopted altered mechanics. And anytime someone continues to run in the context of altered mechanics, you and I both know bone stress injury can set in much faster than people appreciate. And she ended up having, and when she reached out, I said, look, this doesn't make sense. Like, this is not ITB pain. She's saying like her knee didn't feel swollen. We know there's nothing going on from a meniscal standpoint. Not to say that she couldn't have meniscal pathology, but if that was, the tissue that was being implicated, I would expect to perhaps see a knee effusion or to have more joint line tenderness. And this was, a couple inches above that lateral joint line. So you have to put on your cap and your antenna need to shoot up because you need to rule out a femoral shaft bone stress injury. She went to consult some and they said, oh, lumbar radiculopathy. I'm like, bullshit. Oh, you have ITB pain. You have a lateral quad strain. I'm like, how? There would be a traumatic episode. I'm like, when you start hearing this stuff, it's like, no, you need to get an MR and we need to be vigilant in managing that. So, but I think
that's
go ahead.
I think that's one of the benefits about working with a lot of distance runners is that injuries are pretty predictable.
Yeah, common
So
problems commonly happen.
There's just not that many things that runners will come down with.
Yeah.
So having is this an acute event or is this an insidious onset? Most of the running injuries we'll see are insidious in nature unless someone rolls their ankle. So, how did this happen? And then what's the location? And the locations stay pretty consistent with the common running related injuries we see. That's not to say that people don't get misdiagnosed with lots of injuries that are close in location to where their symptoms are, but don't match. And I'll see that a lot too. Anytime people get diagnosed with a muscle strain without a mechanism of injury, that's a red flag. If they have, again, pain in weird locations that don't match, the Achilles tendon or the patella tendon, or again, just these common spots that runners will come down with injuries, I do think that's when pain becomes, you need to do more investigating on that specific pain presentation. Yeah. And it's not to say that you don't have certain instances that are just, that's just a different one. It's rare, it's uncommon, but they can still happen.
I think back to the case that you were just discussing. One of the things that we talk about in the bones, tendons, weights, and whistles course, and again, this is a framework. It just helps to guide your clinical decision making and reasoning. But Bruce Wilk is someone who I spent a lot of time talking to. He's since passed, but I did like his classification system, in describing pain. And I think that he got a couple things wrong that, we've subsequently tweaked that. And, but if you think of that woman that you were just describing, unfamiliar, disconcerting symptoms, right? That's why she's prompting. That's why she's seeing you. Um, so this is only with running though. So like just to walk people through that classification system, stage 1 is unfamiliar, disconcerting pain. And there's a red flag. So there's 5 stages. They go in least severe to most severe. And there's a red flag accompanying each stage, meaning that if that's present or characterizes what you're experiencing, you pull the plug unless you're racing and you see the finish line. So stage 1, unfamiliar, disconcerting pain. Stage 1, red flag, is running with altered mechanics. Stage 2 is pain at rest following activity. Stage 2, red flag, is pain that prevents rest. Stage 3, pain with activities of daily living. Stage 3, red flag, is avoidance. So if you had the option of going up a set of stairs or taking the escalator, you opt for the escalator or the elevator. Stage 4 is pain that is managed with medications or injectables. Being in that stage is a red flag. And then stage 5 is just severely disabling pain that basically makes getting out of bed difficult. So next time a runner comes in, just think like which stage would describe their symptoms. And as you mentioned, Nathan, some of the times this stuff can Toblerone a little bit, but I think the one caveat is with stage 1 that I think Bruce missed, or he didn't explain it in enough detail, because unfamiliar, disconcerting pain, that does it warm up or does it not warm up?
Right.
And that's critical because that's putting you down like 2 very different lines of reasoning, right?
Yeah. And I think in both of those understanding those different stages is really important, because you'll have runners that their pain presentation really is saying they're not ready to be running right now, and they are running, which can keep them in that situation. And then there's other times where their pain presentation is matching the fact that they should be running, or running seems to be sensible right now, and they're not running and they're holding off. And that gets into a whole other situation that you and I will see where, the pain levels might be low, but you're not running. And probably the thing you're dealing with the most is deconditioning right now. Because the longer you stay away from running, the harder it's going to be to come back, which is why we advise so many runners that you should be running with low level symptoms. If you have low level symptoms in training, that's probably okay. Understand the guardrails that we discussed, but the longer people stay away from running, I mean, you and I have seen this with countless people, the harder it's going to be to get back, and the longer it's going to take. And it's going to require a lot more patience, which is challenging for all of us.
Did you come across, I don't know if you've read this paper, the one from Lacey et al. That was in PLOS ONE 2023, that starts to get into some more characteristics or like how they go about describing running related pain. Have you seen that article?
I don't think so.
We can put it in the show notes.
Yeah.
And it's something worth checking out. Tom Goom sort of did a modified version on his Instagram page that goes over this, but it basically, like, they have these various stages, starting from running smooth to experiencing discomfort, to having a niggle, to a twinge, to a persisting niggle, to short-term injury, long-term injury, career-ending injury. And then they talk about physically how they would describe it, its effect on running, effect on daily life, psychological description, whether someone's able to self-manage versus having to eventually like just break down and go see a healthcare professional. To me, it's way too theoretical and elaborate. I mean, I applaud the authors for trying to put something like that together, but I think it will get people just too far down the rabbit hole from a clinical standpoint. But I do think it's interesting to consider just how they conceptualize this. But the thing that was interesting to me with that is that there's no mention of medications. To me, that's such a big talking point, because people, when they have pain, they assume there's damage and inflammation. Like everyone who's not in the medical field, even people who are in the medical field, tend to adopt that line of thought. And then they start being sort of like, sort of laissez-faire about taking anti-inflammatories, or even opting for who knows what, as far as injections go. So, but
Yeah, I've
anyway,
probably mentioned before, the amount of runners I've met with in all the settings I've been in that they'll just take meds like candy.
yeah,
And I think maybe we are getting a little better about that now, but I don't know that it's a drastic shift.
yeah,
And when I talk with patients, you have to have them out of your system. Otherwise, I don't know what we should be doing. You can talk about, the risks of taking NSAIDs and other types of medications and the risks on your heart and your liver and your kidneys and all those kind of things, which are obviously concerning. But I also don't know where to gauge your progress, because if you're like, well, I ran 10 miles yesterday and it was a 2 out of 10, but I took 3 ibuprofen before, I don't know what to do with that. And so
yeah.
I do think you need a clean slate to even figure out where you are right now.
Yeah. Is that something that over the course of your clinical career that you've just taken a much harder line on relative to early on?
Oh, 100%. I mean, I don't even know that I asked that often about it when I was new.
Yeah.
Or if I did, it was a question on the intake forms and not something I explored more. Where, now it is I can't, if you have to take medication to sleep or get through your day or through your job, I mean, I got to respect that. But the focus then has to shift from talking about running to talking about life. Now, most of the people that I see, they're not at that stage. But I do think that you understanding where you are, you got to have medications out of the picture first. Otherwise, you're not going to know. Now, every once in a while, you and I get looped in with people that are, you know, they're at the pointy end of the pyramid. They're at the top of the top, and then it's like the freaking Wild West,
Yeah.
And I might tell you, I don't know that it's a great idea to be taking this stuff right now, but also my opinion doesn't really matter.
Yeah.
Which probably is why people will model that. They'll see something that some athlete's doing, and so then they assume it's a good idea. We see that with just about everything.
Yeah, I'm like you. I used to be pretty loose if I even asked a question, but
Yeah,
nowadays I take a really hard line on this stuff because it's part of a denial process. If a runner is having to take pills or opt for an injection to keep running, I'm like, it's a total flag to me. Um, I would say the one caveat would be if someone is having pain that prevents rest. Maybe. But if they have a bone stress injury or lower limb tendinopathy, that's not doing them any favors if they're taking this stuff. So it's tricky. But you and I both know, like, I've had plenty of people that come in, they're like, I'm having this pain that is throbbing at night and like I am not sleeping,
yeah,
which isn't doing them any favors either. But um, yeah, I mean, maybe that's a one concession that I would make, but it's like, it, when it comes to running, that has to be out of their system 48 to 72 hours. And if they're going to go run, I say, you deal with this. I'm discharging you from my care. And I do take that hard of a line with it because that's a situation where that person needs to be protected from themselves, and like
yeah,
we can't get tangled up in that circus as clinicians, especially if it's a corticosteroid injection, which unfortunately people still are receiving, which
yeah,
shouldn't be the equation. But that's
yeah,
like, okay, minimum 4 weeks, no running, um, especially if it's in a weight bearing joint or if it's in the lower extremity.
yeah. Those highly irritable symptoms too. If people are having trouble with rest and night pain, that happens with bones, right? Sometimes that happens with bone stress injuries. You would expect that to resolve quickly. Like
Hmm.
that shouldn't be present for weeks. It
Yeah.
should be more like days. The ones that I've seen where that is more of a problem is if they're not willing or able to be non-weight bearing for an extended period of time. So maybe
Hmm.
they've got kids or they're like, look, I have to go to work. I understand this isn't ideal, but I have to be doing this right now. And so that is one of those. real life situations where you're trying to help as best as you can. I've dealt with that with patients when they have to go back to work for whatever reason, and they can't do their job and be on crutches for 6 weeks. And so then you're trying to do the best you can. But also running isn't in the equation then. We're not even discussing running at that point.
I think so long as we have confidence or have ruled out through imaging that, a bone stress injury isn't at play, I do like to put this back on the patient, especially if it's someone I've worked with or who is pretty sensible, because people are like, oh, I have pain. And it's like they're freaking out. And, I say, is the pain acceptable to you? I think just as much as we have the pain monitoring model that Silbernagel's popularized, Tomei developed to address, decision-making around patellofemoral pain, I think that it's also important to put that back on the runner or the athlete seeing you, because, if it's acceptable to them and they're not running with altered mechanics, I've run through a lot of pretty unpleasant symptoms, especially when I was dealing with patellar tendinopathy. And I've mentioned this before on the podcast. I was riding around Seattle, and Seattle's very steep. I mean, think of like San Francisco. And I would get up to like 6, 7 out of 10 when I was climbing on some of these hills when I used to work in Capitol Hill. But I had to commute. First off, we only had one car. But I also knew that, hey, there's no energy storage and release. This thing's going to calm down a little bit. So that was acceptable to me. Now, this is our line of work, so we have a little bit more of a refined lens into the implications of this stuff. But I think putting this back on the patient just to sort of see what they're thinking, is very important, something that doesn't always happen.
I think your example is important too, because likely you got to a point where your anxiety around those symptoms was really low.
Correct. Yeah.
And that's not to say that that's what it was always like, because you and I have both had injuries and symptoms and those kind of things where we're still like, do I need to go get imaging of this, of my Achilles, or am I going to have surgery? Like all the stuff that we, tend to help patients work through, we go through all the same stuff. And I think there's a big shift when someone is back to training with symptoms, but they're in that acceptable range and that anxiety comes down. I think there's a big difference with that.
Yeah.
I'll see that a lot with proximal hamstring tendinopathy and navigating hills, or when people start to push back into speed sessions or higher intensity running with the Achilles tendinopathy. Because most of the time, in those two conditions, those specific training environments are the ones that tend to be more aggravating. But once they can get to the point where they feel like they're in control and they know that they have the ability to pull back if they need to, and it's not going to do anything crazy, I think that's when you see a big improvement in recovery. Yeah.
Great point. I wanted to touch on, I thought this would be helpful for listeners. I mean, we could go on for an eternity talking about cases, but this is fresh. This is a fellow who connected with me last night, mid-30s male, gainfully employed, married, has a 3-year-old, and, has a PR of a 3:35 in the marathon, I think is what he mentioned. And for the past 2 years, he's had episodic knee pain, and there is no traumatic event. And he said, I'll be training, and I'll work up to some meaningful mileage. I'll do a long run of say 16 to 18 miles, and then something may come up in life, and I just I'll have to stop running for a couple weeks. I'm like, you're a very atypical runner when he said that. But he's like, when I plug back in, I start like getting I start getting some pain around my knee, and it's sort of diffuse. It's not localized to any one particular region of the knee. Where does your mind go with that?
What do you mean? Give me more. Can you rephrase that question?
Yeah. So, I mean,
where to start with him?
Yeah. Just like things that you would want to rule out to make sure that, so like, obviously you're going to think, okay, differential diagnosis, what are some of the things that could explain diffuse knee pain, um, in this guy's situation,
Sure.
so
Yeah, so you could have a degenerative meniscus tear. You could have, some kind of intra-articular pathology like that.
yeah,
Going back to my, probably not AT band syndrome unless it was just on the lateral aspect of the knee. Could be patellofemoral pain syndrome, all those other kind of considerations. But because he hasn't had any specific mechanism of injury, I'm not super concerned about, the stability or something like that.
yeah, exactly. And this is, again, this is going to be a common presentation a lot of people see is someone comes in with pain in and around their knee. There's no trauma. So again, our advantage is that we can just take people through in person,
Mm-hmm.
especially like to say, okay, so this guy had no knee effusion. He had full knee range of motion. When he would do a lateral step down, he's like, it just feels a little bit like, I don't know, like off relative to the other side. So low level symptoms.
Mm-hmm.
He said, if he's sitting for an extended period of time, this would have been like a key comment or report that, his knee tends to be a little bit more sensitive.
Mm-hmm.
Um, so this is a classic case. It's like, okay, there's no swelling, there's no joint line tenderness, there's no tenderness to palpation. At the inferior pole of the patella, the tibial tubercle, distal ITB, the quad tendon, so you're like, okay, well, I guess it's patellofemoral pain, right?
Yeah.
And he was doing a lot right. I think that was a situation where, I gave him some simple strengthening stuff that I thought, had salience to his situation, but that's more of a conversation almost similar to the woman that you were discussing that,
Yeah.
let's talk about your training. Okay, so you
Yeah.
worked up, but why are you taking these 2 weeks or 3 weeks off at a time? Because you're just going to start to lose capacity. And then these people oftentimes will plug in back to like an 8 mile run. So he said, look, I actually ran this morning. Very important question to ask. Like, hey, tell me about, what's the last week or two look like from a running
Mm-hmm.
standpoint? He's like, well, I did a 2 mile run this morning, so roughly like 20-ish minutes. He said he got up to 35 minutes on a run the previous Monday. And I'm like, wait a second, you're running like once a week right now? It's
Yeah.
like, let's just shorten this. Hey, go out and do, I don't know, a handful of 5-minute bouts and on 1 minute of standing on the runners of his treadmill. He's doing a lot of treadmill running because you have to understand sensible training practices with someone like that, because if you don't, you're going to completely miss a boat, right?
Yeah. That's the, that kind of demographic of patient. I think you can do so much good by just doing what you said, taking them to a walk run interval,
Yeah.
making sure that they're not measuring their next run off of their last run that happened 3 weeks ago,
Mm-hmm.
and trying to figure out, why are we having these bouts of inconsistency? Sometimes life happens, right? Sometimes stuff happens where you have to pull back from training. Maybe it's as simple as saying, like, getting you to stick with a three runs a week of 20 to 25 minutes in those moments where you feel like you don't have the time to run. That's probably more helpful than going completely away, or having you switch that to walking if you need to. Not ideal, but maybe keeping you walking 3 or 4 days a week at 30 or 40 minutes is going to be helpful. So when you can plug back into running, you're not so far away from it. I think a lot of times those simple solutions can be helpful, and that's a very specific, I think, demographic of patient.
Mm-hmm.
Where you'll see that, but then you'll also see the person that's running like 9 times a week,
Yeah.
where they have to pull back maybe because of what they're dealing with. So, yeah, establishing consistency, if that's what you're seeing on a training schedule, regardless of the injury that they're dealing with, that's probably the first thing that you want to focus on.
Yeah, especially if someone tells you they're tolerant of running, like you need to at some point unpack how they're approaching training, because people do some great stuff, people do some silly stuff, a lot more silly stuff.
Well, and just going back to the, talking about pain, if someone comes in and they're like, man, I've been having knee pain when I'm running, and you're talking to them and they're like, well, it's a 1 out of 10 pain when I get to mile 12 on my long run. you're like, well, you're probably not being realistic with what running is supposed to feel like.
Yeah.
I've had a few patients like that where their entry to running is like a movie.
Hmm.
They're like, I'm just clicking off PRs and I'm feeling so good and I love the people I run with and the sky is, blue and the sun is shining and all these things. And then they run into their first level of resistance where they don't PR a race or they feel tired or something starts to bother them. And that's probably the more realistic what running is going to be for you. It's not
Yeah.
going to be all sunshine and rainbows. And so sometimes reconceptualizing that too is also helpful.
I wanted to, I thought this would be really helpful for listeners. Can you talk about, with bone stress injuries, when someone comes in, what you're thinking in terms of where that bone stress injury is in terms of grade is a function of their symptoms?
Oh, sure. So
Yeah.
there's a really helpful narrative. There's a book, I believe Michael Fredrickson is the lead author, called Bone Stress Injuries. I'll put a link to it in the show notes too. But they have a really helpful discussion that I really liked in there. There's papers that have touched on this too. So the idea is that because of how bone is innervated, the when you first feel symptoms of a bone stress injury, stress reaction, or a stress fracture, that's not when the problem started. It probably happened before. It just tends to happen in parts of the bone that aren't highly innervated with sensory fibers. So you literally can't feel it. It's like pinching the back of your elbow. So you're just not going to pick that up. But as it progresses, as it grows in location, and that's how we grade injuries on MRI is by how substantial they look, and if there's an actual line present in the bone, a fracture line present in the bone. So as they progress and that bone starts to lose some capacity, it physically gets weaker. That's when people will start to talk about their intolerance to running. I can't run as far. I can't do exercises in the gym. I can't cross train. I can't go up steps. I can't walk. That kind of deterioration in their tolerance to placing stress on the area becomes less because the actual tissue has weakened. And the thought is, as those injuries progress in severity, as the grades get higher and they become more substantial on imaging, that's when you'll be able to start to pick them up in the clinic. So if you see a runner and it's the first day that they've had symptoms of a bone stress injury, they might say, my hip was bothering me at the end of my 8-mile run and I kind of had to limp a little bit, but then it kind of got better. If that was day one, as you keep training on that, it might not be for a couple weeks to where they're like, man, I can't do a side plank. I can't stand on one leg. It's really hard for me to go up and down steps because the actual bone has lost some capacity. It's not as strong. It's not as well organized because the problem has progressed. So I think it's super, super interesting. And that's, again, some of the uniqueness in just focusing on runners. It reminds me a lot of when Luke Nelson talked on our podcast about the calf and
Mm-hmm.
how soleus strains can be a little bit more nebulous in nature and how they present themselves. And his take was that's all based on how that is innervated.
Mm-hmm. Yeah, I think that's really important when you start, looking at, just what's the afferent input and what are the implications of that in terms of, how it impacts your clinical reasoning. No, it's fascinating stuff. And I've never dealt with, I've never had a formal diagnosis of a bone stress injury. I don't know if I think I at one point may have had one, but I've dealt with clavicle fractures, and
Mm-hmm.
man, those are terrible. And it's because it's like the bone's completely fractured. The cortex, the periosteum's compromised. It's like it's just a hot mess. Um, but yeah, it's like you have that acute pain, and then you have this just residual low level pain. So you're thinking of like, the afferent sensory fibers, like what are the A delta fibers doing versus the C
Mm-hmm.
fibers? And it's like, that stuff's fascinating. But the question is always, what does that mean clinically, when
Yeah.
someone
What do you do
comes
with
in?
it?
Yeah. And I think that
I
the pain that we have to be, go ahead.
No, go ahead.
I think the pain that we have to be very uh, judicious in managing is when people start having this vague, diffuse pain that's not over a tendon or a tendinous region, and you have to really make sure there's nothing sinister at play. People are
Mm-hmm.
complaining about vague pain in the posterior thigh, like, ugh, who is this person we're dealing with? What else is going on? Like, it's probably going to need to get imaging pretty fast in that situation, just because of concern of like an osteosarcoma.
Yeah.
So it's like common problems commonly happen, but if things aren't adding up, like, that's my ultimate special test. When
Mm-hmm.
shit doesn't add up, you need to know what you're dealing with.
Well, and that's why with any of these, if you're dealing with runners, always stay on the conservative side of things. If you're not really confident in what you're dealing with, I'm much more apt now to just say, hey, I think we need imaging before we can proceed. Now, I think as I've had more experience, I'm better at discerning the appropriate initial management. Um, because I had ones that I didn't do a good job of that with. Um, but I think that if your gut is telling you something, just go stay on the conservative side of it. Because the worst thing that happens is the person is out a little bit of money, but you also have the information that you need. And if the MRI comes back that it's clean, it's not a tumor, it's not a bone stress injury, it's not whatever you think it is, then you can now confidently proceed moving forward. I do think that sustaining your own injuries is a very helpful learning experience.
100%.
Anybody that played sports, you pick up stuff, right? So I played basketball growing up, and so I would have ankle sprains and all the other kind of things that you would have from playing basketball all the time. But I had one injury where I got an avulsion fracture of my deltoid ligament, and that's the one time where we were doing a drill and a pass was way out in front of me, and so I had to reach to get to it. And I tried to grab the ball, so I catch the ball and I tried to plant and come back the opposite way in the same movement. And when I did, my ankle just went, and I felt this snap on the inside of my foot. And I kind of walked off to the side, and then I was like, "Oh, that's not good." I've had enough pain before that I know that this is different. And so I think that that's also helpful where you're like, "Oh, you've had all these experiences with different types of low level symptoms. Now you're experiencing something very different, and you're probably going to remember that. Like, oh, I physically can't load my foot. It's just not, I'm going to try to be stubborn about it as best as I can, but this is not normal."
Yeah, getting injured. I mean, I think that's what lands a lot of us in this field, or at least that was the case for me. I think back to some weird stuff that I dealt with, though. I mean, my first knee injury. Every time I would go to hit a backhand and I would plant my knee to stabilize, it was like I couldn't. There was just like a sharp focal pain that I couldn't really put a finger on, but I would like almost feel like my knee was going to buckle. And there's no trauma, so there's no ligamentous involvement. And at that age, I think it was maybe like, I don't know, 14, 15. My mom's like trying to make sense of this. She doesn't know if I'm just bitching and moaning or if there actually is something. And she saw me play, and I think that was, she's like, wow, like you're not able to really load that knee.
Yeah.
And I ended up having an OCD lesion of my femoral condyle, that fortunately, I fell into the hands of Dr. Fu, who recently passed, but thank God I landed under his care just because, he ended up handling it properly. I had no clue. I didn't realize the implications of that. Like, OCD lesions are not great, especially depending on their location. But yeah, I mean, when someone reports pain, you definitely have to start asking questions. And fortunately, we're in a position where we have a good sense of how to examine someone from an orthopedic standpoint, and then how to test them from a functional standpoint where we know what we're dealing with. And that's so empowering, because I think for a lot of the coaches, the greatest challenge is like, unless you have a medical background, if someone's saying, hey, I'm dealing with knee pain, it's like back to Dan John's question. Well, can you go? Like, can you run on it? As opposed to saying, well, wait a second, if you're having calf pain, did this set in towards the tail end of a run as tightness, which, we just touched on, like maybe this is a soleus strain. Was there an acute episode? Maybe someone threw a clot, like maybe walking on it's painful. And you have to have this elaborate line of questioning and reasoning to just make sure you know what you're dealing with. Because if you've ruled out these other sinister things, it's like, oh, carry on. I know you're having some pain. Here's some guardrails that we're going to put on you. But I think that's the most powerful thing for us at this point in our career, is knowing that line of questioning, knowing what tissues could be involved, and advising people in accordance with that, and also engaging them to say, like, what do you think's going on? Is this something that you feel like you can work through, just as much as we may think we know what's going on, to gauge that athlete's understanding of their situation.
I'd agree with you.
Cool. Anything else that we didn't get around discussing that you think ties into this?
I think that's it.
Yeah, a couple of other things that we could probably put in the show notes. The Yamato study, I don't know if I'm pronouncing that properly. That was if people want to say what is a running related injury, that was, I believe, the most recent consensus definition. That's JOSPT 2015, which is just running related MSK pain in the lower limbs that causes a restriction or stoppage of running, whether that's distance, speed, duration, for at least 7 days or 3 consecutive scheduled training sessions, or that requires a runner to consult a medical professional. I do think it's important to be aware of that. And also, generally, running related injuries tend to be caused by running, tend to get worse if you keep running, and tend to improve when you're not running. It's just like working with this stuff in the back of your mind, so the next time a runner presents, like, because if someone's just saying, like, I just have this pain and it's sort of present all the time, it's sort of like unrelenting, well, that's probably something more sinister that you need to investigate, or has the potential to be. So,
or if running doesn't make it worse, maybe running wasn't the thing that happened that caused it. Because you'll see that too, where you'll 100%. Have someone that says something hurts, and then you're talking to them and they're like, yeah, running doesn't really make it worse. Sometimes it feels better when I run. It really feels worse when I do A, B, and C. When I lift at the gym, when I ride my bike, when I sit for long periods of time. Well, in those situations, we probably need to keep you running. And
I see that a lot with people who have back pain or any sort of spinal complaints.
All the time.
Yeah, and I think running is so helpful for that's generally my default, is like, no, we need to keep you running. When I tweaked my back when we were traveling in the fall, running is the one thing that, like, I couldn't wait to run, as well as get into like deep flexion for whatever reason. But I think that's another important reminder.
Yeah.
Cool. Well, hopefully this gets your gears grinding. If you guys have any questions, please feel free to reach out, and we'll put some stuff in the show notes so you have it as a resource. And other than that, we wish you health and good fortune in the year of the dragon.
Yep. Have a good day.
And hopefully we see you in Gig Harbor.
That's right.
All right. Take care. Till next time.